very few of you, Rachel came to us from Yale by the way of rural Mississippi, where she was a math teacher. She arrived here with a really deep commitment to justice, social justice, and access to health. And in her own words, that commitment was sharpened and focused and made more tangible by her experience in the Mississippi Delta. I just wanted to share a line from her application. I was sort of wistfully thinking back many years. And so here's what Rachel had to say a number of years ago. My decision to pursue a PhD stems in part from a strong desire to conquer the intellectual challenge of preparing a dissertation on a unique topic that I can research exhaustively. She has absolutely met that goal and wanted to be pushed to think about health in creative and diverse ways. So you'll get to hear the product of that today. It's been my great pleasure to be Rachel's advisor. I've admired her confidence from the beginning and have been really inspired by her effort over the last couple of months to really push this project through to its end. Thanks also to my fellow committee members for your investment in Rachel, and thank you all for coming. Without further ado, Rachel Fabi.
Thank you, Holly, for that lovely introduction. I wasn't really expecting to hear my words from 5 years ago at that.
So be careful.
And thank you all for coming. I know it's really early, so this is an incredible turnout, and I really appreciate you all being here. And I'm really excited to share with you the work that I've been doing for the last 5 years. I was actually thinking about when I first came across this topic, and I realized it was on a project with Rosa during our HP3 class during our first year, and I've been working on the same policy ever since. So yeah, it's been a long journey, but thank you for being here. I should not have worn eyeliner today. So, my project is on publicly funded prenatal care for undocumented immigrants, and it is a case study in policy, practice, and ethics. So today I'm going to give you a little bit of background about the policies I've been working on, and then launch into the 3 papers that I've produced as a result of my research. And then I'll spend a little bit of time at the end on discussion of the policy and practice implications of this work, and save some time at the end for Q&A. So during my time here at Hopkins, I've cultivated 3 primary research interests, and these are social justice, immigrant health, and women's health. And I locate this project squarely in the middle of these 3 major areas. And throughout my time of the last few years, the main normative question that's driven my work is this question of what we owe to migrants. And when I say we, I mean society conceptualized from the local to the global level. And on this project in particular, I'm focused on what we owe to pregnant migrants. Before I launch into the background, I just want to make a few notes on language. First, in this project, I'll be referring to undocumented immigrants as the morally neutral term. Other terms might be illegal aliens. But undocumented immigrants seem like the most morally neutral term that I can employ here. And it means essentially a foreign-born person who is residing in the United States, but who entered either without permission or who overstayed a valid visa. And another note is that I'll be referring to pregnant women, but it should be noted that not all pregnant people are women, as transgender men and gender non-binary people can also become pregnant. And finally, I'll be using the terms unborn child, pro-life, and pro-choice. This is not a reflection on any particular position on abortion rights, but rather it reflects the language of my research participants and the policies that I've looked at. So on this project, as you can tell from the title, I'm interested in prenatal care for undocumented immigrants. And I find this to be a really interesting topic that sort of focuses those 3 research areas I described earlier, because we have a number of different potential immigration statuses at play here. We have the undocumented mother, who is not an American, but we also have a fetus who, if born in the United States under the 14th Amendment, will be a United States citizen. And this is actually the case for almost 300,000 United States citizens born each year, is that they have at least one undocumented parent. But in spite of that high number of births that follow those particular circumstances, undocumented women are actually more likely than citizens to experience inadequate prenatal care, birth complications, childbirth-related hospitalizations, and they're more likely than documented immigrants to experience low birth weight. And these disparities are due to a number of factors, but chief among them is the policy environment in which undocumented women seek care. So in the 1996 welfare reform, which is abbreviated here as PROWARA, that law barred unqualified immigrants from accessing federally funded health care, except in emergency conditions. And this bar on federally funded care was continued under the Affordable Care Act in 2010, which also barred undocumented immigrants from participating in state and federal health care exchanges. And this is in the context in which these women, undocumented women, are unable to access federally funded health care. They do get federally funded care when they give birth because of the Emergency Medical Treatment and Active Labor Act of 1986, which said that any hospital that receives Medicare funding has to treat anyone who presents in an emergency or active labor condition. So essentially, women are unable to access routine prenatal care, except in a few circumstances that I'll be discussing later. But when they give birth, without having had prenatal care, those births are obviously more expensive. And in fact, previous studies have shown that for every dollar cut from prenatal care for this population, there's a $3 increase in the cost of postnatal care and a $5 cost increase in incremental long-term costs. So, despite these costs, 32 states do not offer any kind of coverage for undocumented pregnant women. And in these states, women can seek care at federally qualified health centers or other community health centers on a sliding fee scale where they pay out of pocket depending on their income. But I'm interested in the 18 states that do offer some sort of coverage for this population. And those policies that offer this coverage are the focus of this dissertation. So the two policies that I looked at in this project, the first is called the Unborn Child Option, which is a Children's Health Insurance Program, or CHIP option, that came into being under the George W. Bush administration. And this allows a state to redefine a CHIP-eligible child as anyone from conception to age 19, instead of from birth to age 19, in order to provide prenatal care directly to the fetus. So this lets states get federal matching funds for any care that is directly provided to the fetus, but they can't receive coverage for any care that is independent to the mother. And how you parse that out was a question that I had going into this project, and something I'll talk about later. So there are 16 states that use the unborn child option. The other policy option that I examined in this dissertation was a state-funded Medicaid expansion, or Medicaid lookalike program. And so when the Welfare Reform Act of 1996 made it illegal to use federal funds, they left it up to states to use their own money to cover this population if they chose to do so. So states that do this don't have any federal restrictions on what the benefits could be. So essentially any woman in these states can get the full scope of Medicaid benefits. And there are 3 states as well as DC that do this. So here you can see the distribution of these policies. The states in red use the unborn child option. The states in yellow use a state-funded Medicaid expansion. And Massachusetts in orange actually uses a sort of a blend of both. And the states in blue have no policy. And you might be surprised to see more traditionally conservative states like Texas, Louisiana, and Missouri using the same policy as more traditionally liberal states, such as California, Washington, and Oregon. I also found that really interesting, and that was sort of what sparked this project to begin with. So this project is a case study of 4 states that have different policies. First, Nebraska, which uses the unborn child option in the way that it was originally intended. So care is only provided to the fetus. We have California, which sort of adapted the unborn child option and names the mother, the pregnant mother, as the beneficiary, despite federal language to the contrary. New York, which uses state funds as a entitlement program. And finally, Maryland, which has no policy, so women seek care at community health centers if they need prenatal care. You don't need to read the aims now, and in fact, I won't be reading any of these aims ever because they're too long, but I want you to know what the structure of this dissertation was. So my first 2 aims were empirical, which means they draw from data, and the third was normative, so I look at more of the philosophy literature to draw conclusions. So the first paper is the policy part of the policy practice and ethics. So in this paper, I looked at the legislative histories of these policies. In the second paper, that's my practice aim, where I'm looking at the effect of these policies on the practice of medicine in each of my case states. And then finally, my third paper, I'm calling that my ethics paper, although there's ethics throughout. This is my normative paper, where I look at a number of normative accounts of what we owe to migrants to see what they have to say about this policy, or type of policy. So, again, you don't have to read this, but in my first paper, I examined the use of moral and prudential reasons in the legislative histories of these policies in order to get a sense of what justifications people gave when they were supporting or opposing them. So my data collection for this aim involved collecting the legislative history documents. Some examples of what that means: there's a snippet of a hearing from California, or a hearing from Nebraska, and this is a transcript where a citizen was testifying in opposition to their prenatal policy, or a court case from New York, and these all sort of make up the legislative histories of the policies in each of the states that has attempted to pass a prenatal policy. I should note that Maryland is not included in this aim because, as I mentioned, it doesn't have a policy and never tried to pass one. So I took all of those legislative history documents and I performed a document review and then a content analysis using an iterative emergent thematic coding scheme. And the goal of this analysis was to figure out three things. First, the narrative, how the policy came to be in each state. Second, the policy requirements, so what benefits are covered, who is eligible. And then finally, these moral or prudential reasons that people used when supporting or opposing the policies. So when I say moral reason, what I mean is an appeal to an ethical principle or an idea of moral right or wrong. And an example of a moral reason might be prenatal care is a human right, or they don't deserve prenatal care because they broke the law. These are moral reasons that have a should component, they're normative. The other type of reason that I looked at were prudential reasons. And this is a term that comes from the literature on immigration, and it means an appeal to the interests of citizens or legal residents. So these could be things like, it's cost effective to provide prenatal care, so it's good for citizens if we provide this care. Or it's good for public health if we provide this care, because you can catch communicable diseases in the prenatal screening process. So the themes that emerged in this analysis broke down into approximately three groups, which I am calling a respect for persons theme, a justice theme, and then these prudential reasons are clumping together. Today I'm just going to talk about the ones in red to give you a sense of what this analysis looked like, but I'm not going to get too deep in the weeds on this and you conceptualize this idea. But essentially it's an appeal to this idea that we should never treat people as a mere means to an end, but always as ends in themselves. This is the Kantian version of respect for persons. But more simply, we could also just say that it's about respecting the rights of individuals. And whose rights mattered differed depending on who was making an argument for or against a prenatal policy. Some felt that the fetus's rights mattered, and others might have felt that the pregnant woman's rights mattered. So to frame this debate, I like this quote from a Nebraska state senator who said that this issue represents a tension between 2 points. It's a balancing test. On one side you have the rule of law, and on the other side you have the pro-life position. And you might be wondering how the pro-life position gets into this. Well, another Nebraska state senator said, "We have an opportunity to understand and recognize that human being, and the fact that we are expending money toward his or her better health is a recognition of the inherent dignity of that human being." So the idea that the state of Nebraska would be spending money on a fetus and essentially conferring fetal personhood upon that fetus was really the impetus for a lot of people in Nebraska to support this policy. So rather than an interest in actually providing health care to pregnant women, it was about creating a precedent where that fetus had personhood. Interestingly, not one person in Nebraska made any reference to the inherent dignity of the human being who was the mother. And on the sort of flip side of this, you'll recall that California has the same policy as Nebraska, which you might find strange given these reproductive rights implications. But actually, the state of California embedded in the language of the policy that California protects the woman's right to reproductive privacy. And they also named the mother as the beneficiary, which caused some consternation because the federal rules said that the fetus was the beneficiary, but they accepted their state plan amendment regardless. The other category of moral reasons that emerged through this analysis had to do with the principle of justice, and this is the idea of treating similarly situated groups similarly, and if we're going to treat them differently, we have to have a morally relevant reason for doing so. So An example of this might be if the Department of HPM decided they were going to give health insurance only to their blue-eyed students, but not to their brown-eyed students. We would say that that's a morally irrelevant characteristic and that's unjust. However, if the Department of HPM said they would provide health insurance to their own students, but not to students in biostats, we might think that that is a morally relevant distinction. So what counts as a morally relevant characteristic differed depending, again, on who was trying to argue for or against the policy at hand. So one characteristic that emerged as morally relevant across multiple debates in different states was this idea of social membership, and the idea that the fetus, when born, would be a citizen, or in this case, would be a future Nebraskan. So that community that would be welcoming the fetus mattered morally, the fact that that fetus would then grow up in Nebraska and have social connections, entitled it to health care. And this idea also emerged in New York. The bill that created the state funding mechanism in New York said that the child who, if born in the United States, is a citizen and eligible for government-funded social and medical programs, that I left off the first part of that quote, but the idea is the child would be born, would be a citizen, and then would be eligible for other social programs. So not only do we see a social membership aspect here, there's also an appeal to a prudential reason here. It saves money if we provide this child with prenatal care in utero. And so that's a prudential reason. Another example of this would be an appeal to economic interests of the state. So actually it's another example of the same thing, but the idea that provision of prenatal care will result in lower medical expenditures. That was also embedded in the bill of the Nebraska, or in the Nebraska bill that created the unborn child option in Nebraska. So again, in the interest of time, I'm not going to cover the rest of these themes, but if you have any questions about other things you see up here, I'm happy to talk about that in the Q&A. And I'm also going to put off most of the discussion of the same to the end, but I do want to say that different reasons emerged across different states, as you might expect. But the policy effect across the states was more or less similar. In each state, undocumented women could get access to prenatal care and it would be covered by insurance, whereas in states that didn't have any policy, they couldn't get it. So essentially the policy effect was the same, although there were some differences in what benefits were covered. And those benefit differences weren't super clear from the legislative history, so that was something that I hope to get out of my second aim, where I tried to ascertain whether these policies were experienced similarly by providers. So that brings me to my second paper. Doing on time, good. Okay, so in this aim, I sought to explore the effect of these policy restrictions on providers and their ability to live up to their professional norms. And so what I did here was I spoke with healthcare providers and staff in one urban and one rural health center in each of my case states. And so you can see here the distribution of my recruitment goals. I sought to recruit 4 people in each health center, one primary obstetrical provider, one non-primary care provider or nurse, one social worker or patient support worker, and one person who did billing or administrative work in the health center. And you can see, it's kind of small, the distribution of my respondents here. You'll see I sort of overshot my recruitment. I actually ended up with 34 instead of 32 respondents, which was great. And I highlighted in red here just to point out that social workers were overrepresented in my sample, not intentionally, but they just expressed more interest in participating than other provider groups. So these interviews lasted between 20 and 60 minutes and were conducted by phone, and they were broken down into 3 parts. The first part of the interview sought to ascertain information about their background and the background of their health center. The second was about the process through which undocumented women accessed prenatal care in their health center. And the third was about their professional norms and ethical tensions that they encountered while providing or facilitating this care. So my findings I'm going to show them in 2 groups. One is these professional norms, and the second is going to be focused on those ethical tensions that they encounter. So the professional practice norms that emerged through this analysis, the most common was to treat all patients the same. Actually, equally common was to advocate for patients And the third most common was not to ask patients about their immigration status. And you'll see here I'm reporting frequency. I want to point out that this is not to say that this is generalizable. You can't say, well, 24 out of 34 people believe this, so like 68% of providers believe this. It's not generalizable in that way. I'm more reporting it just so you can see the relative frequency. So treating everyone the same was the most common theme, or tied for first. And this was this idea that you don't differentiate between your patients on the basis of their immigration status. So I had a nurse from Maryland who told me, a nurse midwife from Maryland who told me that she treats everyone as if they were her own daughter. And similarly, a nurse from rural Nebraska told me that she does everything the same, no matter if they're documented or undocumented. And she said something else that I found really interesting. She said, that's why I'm here. And I think that this there's two things that are important here. First, it should be noted that I sampled only from community health centers. So the people who are working in these community health centers may feel particularly driven to serve this population. And in this case, she feels particularly driven to treat all of her patients the same. She's here to do the exact same thing for all of her patients because she cares about this population. The second theme that emerged on the professional practice norms was to advocate for patients. And this came out in one of two ways. Either my respondents told me explicitly, yes, my norm is to advocate for patients, or in this case, my norm is to reduce the barrier of care for patients, which is arguably the same thing. And she also repeated this idea of we work here for a reason, so I saw that actually quite a bit in my data. But the other way that advocating for patients emerged was sort of implicit in the anecdotes that some of the providers told about their experiences caring for undocumented patients. This patient support worker from Maryland, which, as you'll recall, has no policy to cover prenatal care for this population, had a very difficult time getting her patient covered when she went to the ER. This patient went to the ER, received a very high bill, and this support worker contacted the hospital and arranged charity care. So in this case, advocacy for patients was implicit in her description of her actions rather than an explicit statement of her norms. Finally, and this is sort of in a different direction, my providers frequently told me that they don't ask about immigration status. So they don't like to make their patients feel uncomfortable or questioned, and that's wonderful. And this could be an instance of really showing good respect for your patient and respecting their privacy. But it could also be a case of avoiding confronting a potential determinant of health head-on, because immigration status does have an effect on health because of the stress related to undocumented status. So the second category of findings from this paper involve ethical tensions and frustrations. So these are the things that happened when providers felt they couldn't meet those norms because of policy restrictions. So first, providers told me that they felt unable to provide all necessary services to this population. And then second, they also told me that their patients' fears related to status affected their ability to access care, and they were frustrated by that inability or that challenge. So in terms of being unable to provide necessary services, Maryland, as you'll recall, has no policy. So although women can seek care in community health centers, their access to specialty care is particularly limited. So this nurse midwife from Maryland told me that she felt that her hands had been tied in terms of getting her patient access to specialty care, and that this was very distressing for her. I also had the benefit of speaking with a provider who had previously worked in California and now works in Nebraska, so she was able to comment on the different implementations of the unborn child option between those two states. And she told me that the limitations that are imposed by the unborn child option in Nebraska are arbitrary and asinine. And she said that if you want to be cost effective and provide proper care, you need women's health as a whole. This other idea of fears related to status affecting care was true across all states. This nurse from New York told me that her patients were afraid to access health care because they were afraid they were going to be identified as undocumented. And she and others actually indicated that this had grown worse since the 2016 election. And she also said that they were presenting later for care. So women would wait until later into their pregnancy until they absolutely needed to come in for care, again, because of fears related to their status. And this was true across states. So when my providers encountered these tensions, these frustrations between what they felt they should do and what policy said they should do, we saw some workarounds or rule bending emerge. So a physician from rural California described how she would have to maneuver patients around the system and get creative in order to get her patients the care they needed. Although she was quick to point out that she never broke the law, but some other people do. And I also heard in New York about people trying to sneak in care during the period of coverage. So a pregnant woman has care until 2 months after she gives birth, and then that care drops off. So they were trying to sneak in services, provide services that might not have been immediately necessary during that time when there was coverage. And this is an example of sort of working around that policy barrier to providing care all the time. So these workarounds emerged in response to what's known in the ethics literature as moral distress. And this is the idea of an acute feeling of risk to one's own personal and professional integrity that is associated with the perception of powerlessness to prevent some wrong. And this quote sort of accurately captures the feeling that a lot of my respondents described when it came to trying to get care for their undocumented patients. And this was especially true for providers who told me we work here for a reason. You know, they want to be able to provide all necessary care to their undocumented patients. So what are they to do when the policy conflicts with their professional norms? As we saw this emerged, this resulted in workarounds and rule bending. So Nancy Berlinger, in her 2016 book, The Ethics of Workarounds, describes a number of categories of workarounds that providers use when they encounter policy or institutional barriers. One type of workaround that she describes is a norm of avoidance. So we can kind of see this with the not asking about immigration status. If you're a provider and you know that knowing your patient's immigration status will create more work for you because now you have to figure out how to get them care, you might just not ask, not open up that conversation in your own interest. Another type of workaround that she described was rule bending, or this idea that you would maneuver people around the system again, or sneak in care. And this is done in the interest of the patient rather than in the interest of the provider. You're trying to get that patient what that patient needs. But this isn't an ethically neutral concept, right? Because that individualized response might work for that individual in front of you, but it doesn't really contribute to systemic change and actually might help perpetuate a system when you're only treating each patient in front of you. And similarly, there might be issues with who you decide to bend the rules for, reflecting bias in who you find to be a difficult patient or a patient worth bending the rules for. So this sort of ties back to my question of what we owe to migrants, and specifically pregnant immigrants, in this non-ideal context where there are resource constraints. So when I conceptualized this project, it's sort of a practical test of our conception of justice. The norms that drive our policymaking have to be compatible with the norms of people who practice medicine under those policies. And when they're not compatible, we see this tension, this moral distress. So the findings from this project sort of show that either our conception of justice has to change or our policy has to change. So in my third paper, I sort of explore this tension through a number of normative frameworks. So paper 3 examines 3 accounts of moral obligations towards immigrants to see if they can agree on a policy judgment, so what the policy should be. So this paper was kind of a greatest hits of my time here. Basically, I worked in all of the books that I most enjoyed and that most spoke to me about this topic. Joseph Karen's The Ethics of Immigration was my textbook for the class that I taught twice. Hey guys, some of my undergrads are here. The Health of Newcomers is a book by Wendy Permit and Patricia Illingworth that came out last year, and I have a review of that in A-Job. And David Miller's book was sort of the one that most challenged my intuitions, because Miller is here representing a more statist position, a more inwardly focused wall-building position, if you will. I also incorporated Rawlsian and Kantian concepts into this paper. I've left the Kant out of this presentation, so don't worry. But I am going to talk briefly about Rawls. So in this paper, my goal was to locate what I'm calling an overlapping consensus, which is the idea that despite a diversity of doctrines, convergence on a political conception of justice may be achieved. Now, for the philosophers in the room, I know that what I'm doing here is not a true overlapping consensus because I'm not looking at the basic structure of society, but I'm sort of adapting the idea to the specific context. So don't worry, I know that that's not actually what it is. So I've taken these three accounts, Karen's, Illingworth and Parmit, and David Miller, and I'm looking to find what they might agree on from a policy perspective, what solution is correct here. And from the get-go, they do agree on one thing, and that is an idea of cosmopolitanism to greater or lesser extents. And cosmopolitanism is this belief in the equal moral worth of all human beings. As I mentioned earlier, Miller is my statist, so he is slightly less wedded to this idea than the other two, but he says he believes it, so we're going to put that in the middle. Okay. So Joseph Cairns, he argues that living in society over time makes one a member, and being a member generates moral claims to legal rights and to legal status. So for Cairns, time is the crucial element, and the longer you've lived in a place, the more connections you have, the stronger your claim on membership rights. So if you live in a society where healthcare is a membership right, and you've lived there for a long time, you have that same right. But this has implications for newly arrived pregnant immigrants, right? Because they haven't spent the time to develop those membership rights. Similarly, it could have implications for children and newborns. They haven't been alive that long, they can't develop those time connections either. But Karen sort of anticipates this argument or this interpretation of his theory and says that social formation or the expectation of social formation also matters. So what this means is if you were born in the US, we expect that you're going to be, to receive your social formation here, you're going to grow up as an American. So Karen sort of works through this idea, first by talking about how we give citizenship to the children of citizens for that reason. That's why we have birthright citizenship in the US. If you're born here, we expect you'll live here, grow up here, be an American. Similarly, we provide birthright citizenship to the children of immigrants for the same reason. So an extension of Cairns' argument could be that we would give similar membership rights to the fetus. And this kind of resembles the unborn child option, right? We're conferring citizenship ahead of time to that fetus when we provided membership rights and CHIP funding. Now, some might be concerned that this would undermine reproductive rights if we're giving membership rights to a fetus. But I want to note that the important factor here is that you actually expect that the child will receive their social formation. So if a pregnant mother has no intention of giving birth to that child or has no intention of raising the child in the United States, then those membership rights are moot. So this is sort of one way to get around the reproductive rights implications of conferring membership rights on a fetus. But ultimately, I would argue that Cairns' theory would support a policy that provides prenatal care to undocumented women. The second account that I looked at is that of Wendy Parmit and Patricia Illingworth. And their theory is sort of two-pronged. The first part of their policy they call, or the theory they call the global public goods approach. And I'm not going to get too deep into what a global public good is at this point, but the gist of this argument is that if health is impacted by social determinants, social capital, and norms, and we live side by side with newcomers, we cannot easily remain unaffected by their health. And newcomers is what they call immigrants, but the idea is their health affects our health, so we should provide them with health care. And this is sort of an appeal to prudential reasons, similar to those that we saw in the first aim. Some people might find that unsatisfying because appeals to prudential reasons don't seem, we might want to argue that women have right to health care in their own right rather than because of us. So the second part of their theory appeals to solidarity, which is a collective commitment to carry costs for others. And solidarity duties come about because of community, because of connections, so similar to Karen's, the fact that we're working towards a common goal and have shared experiences, these generate moral obligations on other community members. So Parliament and Illingworth argue that we have solidarity obligations to carry costs for newcomers, and this too might generate an obligation to provide prenatal care to undocumented women. Finally, David Miller's Strangers in Our Midst. As I mentioned, he's somewhat less cosmopolitan than the other two theorists. When he says he's a weak cosmopolitan, what he means is that we are required to treat all people with equal concern, but that does not in general mean that we have obligations toward them, unless their claims against us become urgent, when failing to meet them is likely to cause significant harm. So how we define urgent here matters a lot in determining what we owe to people. When Miller is considering what is an urgent human right in the context of what we owe to legal residents, Miller says that subsistence, shelter, healthcare, bodily integrity, and safety at work all count as urgent rights because failing to meet them could result in significant harm. He also then moves from this idea that these are rights for legal residents to the idea that they should also be rights for undocumented immigrants living among us because of the idea of legitimacy of the state. So he says, a state that claims authority to apply its laws to everyone within its territory must also protect the human rights of all those present, whether legally or not. So if for Miller these six things, are human rights for legal residents, the nature of a human right is that it's universal and you get it by dint of your humanity, so it also applies to undocumented immigrants. But going back to that idea of urgency, there were people in Nebraska who argued that prenatal care is not urgent, and in fact they argued that they were totally fine with undocumented immigrants using the emergency room, but they did not think that prenatal care was sufficiently urgent to warrant government intervention. But even if we disagree that prenatal care is an urgent right, there are other parts of Miller's account that could justify the provision of prenatal care to this population. Miller, like Cairns, believes that residence over time may also matter. The immigrant is likely to have entered into a system of social cooperation centered around the workplace, but extending beyond that to include leisure activities and so forth. These interactions are governed by norms of reciprocity. So the idea that undocumented immigrants have paid into a system, have paid taxes, have created connections with other people in society, creates obligations from society towards those immigrants because of reciprocity. And this might be particularly persuasive in the place where the undocumented immigrant pays his or her taxes. So, I conclude that we can locate an overlapping consensus or a consensus account of our obligations to pregnant undocumented immigrants among these three accounts, and that in fact we do have this obligation. All right, so just a little bit of time on some policy and practice implications. First, throughout this project, what became really abundantly clear to me is that there are a variety of ways to frame prenatal policies for the public. So, as I mentioned, there are 32 states that don't currently have prenatal policies, and I think the evidence from paper 1 and also some from paper 3 could suggest that there are ways to frame policies to make them more palatable to different crowds. So for instance, if a state that currently doesn't have a prenatal policy but has a very conservative population, if they were interested in passing one, they could look to the unborn child option and make arguments based on fetal personhood. Or states that are concerned about those arguments could look to California and frame it as a reproductive rights option by embedding the language that California did into the policy. Similarly, we could appeal to ideas of social membership and the idea that we see in the news all the time about the DACA, Deferred Action for Childhood Arrival kids, that they're members of our community and therefore deserve membership rights. So that brings me to my second policy implication, which is that there are policy opportunities to extend healthcare to other undocumented populations. So I just mentioned DACA, and as we've heard in the news over the last several weeks, these adults who were brought to the United States as children received their social formation in the US. So an appeal to Karens and this social membership idea could justify the extension of healthcare membership rights to that population. Similarly, undocumented children currently only have healthcare coverage in 6 states. So I think that there's a real opportunity to appeal to this idea of social membership to extend healthcare rights to these children in other states as well. My third policy implication derives from my second paper, and this is the idea that the provision of more generous benefits to undocumented immigrants could help reduce moral distress in providers. Now I know the burden of these policies falls much more heavily on the immigrants themselves than on the providers, but that's a different paper. Finally, I have a couple of practice recommendations. First, that healthcare institutions should provide workers with a safe environment in which to discuss the ethical tensions and workarounds that they encounter as a result of these policies. Providing providers with time to have critical self-reflection on their workarounds and patients that they see as more or less worthy of intervention might be useful both for the provider's distress and also for the patients in that healthcare institution. And furthermore, these sort of opportunities could allow health institutions to systematize the legal workarounds if they know what everyone's doing and it's an unjudgmental safe zone for them to discuss their workarounds. It could be easier for them to systematize them. And my final practice implication is that providers should create opportunities for patients to discuss their immigration status. And this is not to say that providers should directly ask their patients for their immigration status, but rather that they should create opportunities. And there are a number of professional medical organizations that support this idea that because we know that immigration status affects health, it could be an important thing for providers to know. So this is the part where I read because it's written out. So one second. This project provides insight into the range of arguments that could be used to support an immigrant health policy and demonstrates that stakeholders with diverse political or philosophical viewpoints can sometimes find common ground on policy solutions to complex problems. This project also examined the real-world impact of policy restrictions on the practice of medicine. Healthcare workers are unable to fulfill professional norms because of policy constraints. Healthcare workers who are unable to fulfill professional norms because of policy restraints must navigate the line between advocacy and role bending, which is ethically unsustainable and causes real moral distress. In the past year, the political discourse surrounding immigration, women's health, and healthcare generally has become increasingly incendiary. Although this dissertation focused primarily on access to prenatal care for undocumented immigrants, the findings of this project could have wide-ranging implications for other immigration and health policy issues. When arguments supporting or opposing policies are frequently boiled down into tweet-sized sound bites, the language that policymakers use when they defend a policy position matters. The findings of this project suggest that common ground on these issues can be found by appealing to a range of moral and prudential values shared by stakeholders across the political spectrum in the pursuit of justice in the policy, practice, and ethics of immigrant health policy. So, thank you guys for being here. Thank my committee. I'd like to thank my committee, Holly Taylor, Brendan Saloner, Matt DeCamp, and Kate Smith. They've been with me since the beginning. These guys were all on my orals committee, and I've really appreciated their support all the way through. I also want to thank Mike DeStefano, who served as my second coder for AIM 2, Lisa DeCamp, who helped me pilot my interview guide for my second paper. I need to acknowledge my funders, so the Center for Qualitative Studies in Health and Medicine, the Agency for Healthcare Research and Quality, an ARC NERSA training grant that supported my first 2 years here, the Richard M. Danziger Fund, the Care First Hal Cohen Memorial Scholarship, and the Barbara Starfield Scholarship have all supported my last couple of years here. And finally, I want to thank my friends and family for all their moral support over the years. So I've got my cohort, my family, my friends, my cat, my dissertation writing group, and most especially my partner, Megan Monfort, without whom I could not have made it through the last few months. So, thank you.
Thank So we have about 15 or so minutes for questions and answers, and then we're going to send all of you but the committee out. So Mariah, please ask your question.
So Rachel, that was excellent work and really clearly presented. Thank you so much for the talk. I have a question about the second of the three books that you mentioned, by Prenatal and Illingworth, and the appeal to solidarity as a moral reason. So I'm curious about how they defend that appeal against a libertarian objection. You know, because a libertarian can say, well, yeah, metaphysically, I just don't believe in this type of obligation, and I don't believe, you know, therefore our taxes should support this kind of care. So how would they defend the appeal to solidarity against that objection? And in the event that the defense of that position against that objection didn't succeed, how important is the appeal to solidarity to the whole position that you found in the convergence amongst the theories?
So I don't know that they make any particular effort to defend against a libertarian critique. I think they would probably say to that libertarian, we'll look back at the global public goods half of our argument. In terms of whether that makes their overall argument fail or how important it is to the overall argument, if it can't defend against that critique, you know, I think that a libertarian would probably not be convinced. And I don't think that that makes their argument overall unsuccessful. It just makes it unsuccessful to that person.
And if I could just follow up, is there a way in which you would defend your position against libertarianism?
I don't think I said what my position is, which was very intentional. But I think that if there is a person who believes that we don't have obligations towards people who live in our community, say for instance we're talking to Peter Singer, who I don't think we would necessarily describe as a libertarian, but who doesn't think that proximity matters, we can still make appeals to the overall utility of the provision of health care to that population. You know, if we wanted to translate that prudential argument into a moral one, we could appeal to utilitarianism.
Yes, Travis.
Awesome job, Rachel. It was really cool to see it finished and all together. So a related question to Mariah's, I think. I, in general, think that looking for consensus positions is a really promising way to move forward in this non-ideal space, so that makes total sense to me. What I wonder about, what I'd like to hear you say something about is even your status is a weak cosmopolitan, and so I wonder to what degree you think it matters to the argument that surely there are strong statists who won't endorse the kind of consensus position. And, you know, I can see different reasons to still care about this, so it's not a kind of takedown, but I wonder if you think that we have this conversation in one space, right, and move one thing forward, or if you think that the consensus argument still kind of matters in a strong sense, even without strong statists being in the room, I guess.
Yeah, so two things about that. One is that I actually looked for a strong statist, and the best I could find was Miller. There's not actually a ton in the political philosophy literature that, you know, that refuses to subscribe to the idea of the moral equality of all humans, right? That's sort of a little bit out there of a position to declare yourself. But I think that I very intentionally focused, you know, I chose these accounts knowing they were all at least moderately cosmopolitan, and I'm okay with my argument moving the needle forward in the one sphere rather than trying to answer all the things. At least on my dissertation, I was okay with keeping it narrow.
Yeah, I mean, and part of what I thought is that more strongly statist views than Miller, it sounds like, I don't know Miller's work, could actually still endorse what you're saying.
Yeah.
Right? But I guess your answer is that you just didn't actually find one as an example.
Yeah.
Okay, cool.
Yes, Alexis.
Yeah, again, thanks so much for the talk. Really, really great. So I was wondering if you would be willing to comment on the morality of prudential argumentation.
Like the morality of using prudential
Yeah.
arguments?
So I mean, you say there's lots of ways to make these arguments, you know, to get the policies in there. They have the same. You kind of imply they have a similar. These different arguments have a similar outcome, but it perhaps matters what kind of argumentation gets used. So I wondered if you could speak to that a bit.
Sure, and I do get into that a little bit in my third paper. That's the Kantian aspect of the paper that I left out here, but I mean, I think in politics you use what arguments you can get, right? So while it might not be necessarily palatable to make arguments that we should do this because it affects us, those are effective arguments for a large segment of the population. So at least from a utilitarian standpoint, if our goal is to get the outcome that we want, we use whatever arguments we have available, which may not be satisfying.
Other questions? Yes, please.
Rachel, I was wondering if you could, this is the historian in me talking, if you could talk about the interviews that you conducted and what sort of questions you were asking of the respondents.
Yeah, so I was interviewing providers and staff, and I asked them about, I was really interested in finding out what these policies look like on the ground first and foremost, because you can only learn so much from the documents. So I wanted to know what the experience was, like what benefits are actually provided. So I asked, walk me through a typical day when an undocumented patient shows up for the first time, and talk to me about all of the services that are provided, who do they see, what's covered, and that sort of got at the first part, and then I asked follow-up questions about how these services were paid for, and what other non-medical services the health center connected these patients to, whether they had group classes for prenatal care or that sort of thing. So that was the first part of the interview. And then in the second, I asked them first to describe their professional norms. So without giving them context, just like what are the norms? What are norms of a physician, or what are the norms of a social worker in your job, in your professional duties? And then I asked them specifically with regard to this population, how do your norms apply? And then I sort of tried to elicit responses regarding well, with this population, I can't do X or I can't do Y, and my norm is to treat everyone the same, but sometimes I can't do that, and then I would follow up through that. Yeah.
I'm going to take the advisor's prerogative before I get to Christian. The question just, was there anything in those interviews that surprised you that came from their perspective, or was it, sort of what you imagined they might be saying?
It was definitely not what I expected them to say. And that reflects more my own naivete with regard to providers than, I probably should have expected that they would take these interviews in sort of a moral distress direction. I was hoping that they would comment on my, driving question, what do we owe to immigrants? I was hoping they would say, well, yeah, they're immigrants, but it's a human right, or something like that, and just no one wanted to talk about that. They wanted to talk about how the policies affected them in their practice. Which is partially, I should have expected that, but also I could have worded my questions a little bit better to elicit that kind of response. So that's on me, and that's how I ended up with a paper too that doesn't totally answer the question, what should we owe to immigrants, although I had hoped it would.
But yeah, my question is actually about the moral distress direction. I really like that you incorporated Nancy Berlinger into there, but when you were explaining her categorization of the different workarounds, I think you presented norms of avoidance and norms of rule bending.
Mm-hmm.
You also made a distinction between one appealing to the interest of providers and one appealing to the interest of patients. But that distinction I didn't really see the basis of that distinction. Could you say a little more about why those two norms fall into those two categories?
Yeah, so it doesn't map directly onto it, right? Not asking about immigration status sometimes came out in the interviews as part of people saying that they treat everyone the same. So it actually fell under that previous norm. And sometimes it was mentioned independently. But in Berlinger's book, she's writing not just about this population. She's talking about workarounds in general in healthcare. So she'll say a norm of avoidance might be a nurse not making eye contact with her patient, because if she makes eye contact with her patient, then she needs to talk to the patient more, and it takes time, and that takes time away from other patients. So that's a workaround that nurse has developed. So it's not a perfect parallel. I admit that the framework doesn't map exactly onto it, but I would say that the not asking about immigration status is closer to doing that sort of thing, and avoiding, having to then maybe track down additional resources for this person who doesn't automatically get them. And then the relationship between that and the rule bending, if you did ask their immigration status, and now you know that they have needs that they can't meet, now you might go out of your way to make sure that they can get them. And that's done, when you're a provider and you see different levels of access to care for different populations and you think that's unjust, you're more likely to bend the rules for that patient. And I guess it's partially in the provider's interest, right? It's to ease their own distress at that situation. So that's a fair criticism of Berlinger's framework, I think.
Well, thank you all for coming. Thank you, Rachel, for the presentation.